Welcome to AETCM, the Emergency Medicine Channel. I'm Shaila sir. Present in the case of a 44-year-old female who presented to ER with an alleged history of deliberate self-harm by consumption of 10 tablets of tryptomer, which is Amitriptyline 25 mg, about 10 hours back. On initial 10-second assessment, the patient was conscious, but she was drowsy but arousable, and she was able to complete full sentences, and airway was patent. There was no pooling of secretions or gurgling sounds or stridor. Breathing, the respiratory rate was 18 per minute with a saturation of 100% in room air, and air entry bilaterally equal. The chest was clear and there was no presence of any added sounds. On the circulation part, the pulse rate was 82 per minute and the BP was of 110/70 millimeters of mercury, and all peripheral pulses were palpable and equal, and the capillary refill time of 2 seconds. And disability, the GCS was E3V4M6, and the pupils were equal and reactive to light, with a size of 2 mm, and GRBS was 120 milligram per deciliter. And exposure, the temperature, she was febrile. There was presence of multiple hesitation cut marks present on bilateral forearm. Adjunct to the primary survey, we initially took an ECG. ECG showing a isolated T wave inversion V2, and QTC was 485, and so it was, otherwise it was normal. And we also took a venous blood gas showing no acidosis or alkalosis with HB of 12.1, potassium of 3.4, glucose of 131, sodium of 136, and lactate of 1.9. and creat of 0.53, bicarb of 24.9, and then we moved on the sample history.
Okay, so we'll go back again. So we have a patient with injection of what? Amitriptyline. So it is a what agent?
It is actually it's an antidepressant. It's a tricyclic antidepressant.
Yes. Okay. So we have a patient with tricyclic antidepressant. So what kind of tricyclic antidepressant is it?
It is actually a amine component of.
So we have different antidepressants. Which are they? Typical antidepressant, cyclical antidepressant, atypical antidepressants are there. Then
we have the
MAA inhibitors, SSRIs are there, SNRIs are there. So what is the peculiarity of tricyclic antidepressants?
Tricyclic antidepressants, they have a property of having.
What does the name suggest? 3 cycles. Tricycle. 3 cycles are there, and it is having a side chain. Okay. Yes. And it itself is classified into 2.
Yes.
What are
so
they?
It is classified into tertiary amines and also secondary amines.
What is the peculiarity of tertiary amines?
So in tertiary amines, they basically have 2 methyl groups in its end of the side chain. So basically, its examples include amitriptyline. Amitriptyline example, clomipramine, doxepin is an example, and also imipramine. And they usually act in by blocking the reuptake of serotonin. So serotonin, and also it is the action of blockade of serotonin receptor is more than the action of norepinephrine uptake receptors.
You are talking about secondary, right?
No, tertiary.
Tertiary. Okay.
And it is having a more anticholinergic effects compared to the secondary amines. So
what is secondary?
In secondary, there is presence of only 1 methyl group at the side chain. So there will be examples are disipramine, and it's usually having a increased action of preventing reuptake of norepinephrine.
Okay. So basically, tricyclic antidepressants are of 2 types, either secondary or tertiary. Secondary amine means, as we told, anyway it is having 3 cycles. Along with that, 1 side chain is there. In secondary, the side chain is connected to 2 methyl groups. It is connected. So, and the peculiarity of secondary amines is that it is having a tendency to block the reuptake of norepinephrine. So, as we know, in a junction, there will be usually what is happening. So, these are antidepressants. In depression cases, there will be from the synapse, from the presynaptic region, that norepinephrine will be released, and the postsynaptic region, it will be absorbed. So if the amount of norepinephrine in that synapse is very less, what will happen? Patient will have depression symptoms. So what usually when this norepinephrine is released from the presynaptic area, it will be it should go to the postsynaptic region. Otherwise, it will be reuptaked. So that reuptake will be prevented. So same as the scenario with serotonin. Whatever is released from the presynaptic area will be taken by prosynaptic area. If that is happening normally, patient won't have depression. But what is happening, instead of this going to the postsynaptic region, it is getting reuptaked. So that is, we are trying to inhibit that. So we are having secondary amines, tertiary amines. Secondary amine, it is connected to 2-methyl group and it is having a tendency for inhibiting the reuptake of norepinephrine. Norepinephrine also, if at all it is not getting absorbed to the postsynaptic region, patient will have depression. So secondary amine is focusing more on the inhibition of reuptake of norepinephrine. Then comes the tertiary amine. Tertiary amine, it is attached to, instead of 2-methyl group, it is getting attached to one H plus and one methyl group. Only one methyl group is there, and it is more in charge of preventing the reuptake of serotonin. Okay. So secondary amine inhibits more of norepinephrine reuptake, and tertiary prevents more of serotonin.
So that's the difference in how it comes. And usually...
So in primary survey, what all things are... So you know that this is a case of tricyclic antidepressant toxicity.
Yes.
Primary survey, what all things will you check?
Initially, in the initial 10-second assessment, we must check about the patient's consciousness, whether she is able to complete full sentences, like what is her sensorium in the initial presentation. That's what is the initial important thing in what she is present. Then we must look, if patient is drowsy, we must look for the airway patency. If patient's airway is patent or not, like if there is presence of any pooling of secretions is present or not. But usually in cases of tricyclic antidepressant poisoning or toxicity, there will be a presence of drying up of secretions. So it is less likely.
Why you told there will be drying of secretions?
So it is due to the anticholinergic action. Tricyclic antidepressants have an anticholinergic action.
Okay. So what are the other actions of tricyclic?
So the other actions of tricyclic antidepressants.
So far we have told our indication of giving this tricyclic antidepressant is to prevent the reuptake of norepinephrine or serotonin. Then it is having extra other actions which can cause some side effects also.
Yes. So basically the presentation, it can be because of many receptor. It's based on the receptor. So if there is a presence of an antagonism in the postsynaptic histamine receptor, so if it's acting against the histamine receptor, patient will be presenting the presence of sedation. So like action of antihistamines, sedation and reduced consciousness. So that will be the presentation. If patient is having an antagonism at the postsynaptic muscarinic receptor, so in muscarinic, if it's acting in the central muscarinic receptors, patient will be having a presence of agitation or even delirium, or present with confusion, presence of amnesia. Presence of hallucination can also be present, or patient can present with slurred speech or ataxia, mimicking a stroke. And also patient can present it as sedative and again coma, can further worsen into a coma. Peripheral signs of muscarinic receptor action, like blockade, is mainly by the action presence of dilated pupils. Dilated pupils, and patient can also present it as blurred vision. And also patient will be anticholinergic action like tachycardia. There will be increased tachycardia, hyperthermia, hypertension, decreased oral and bronchial secretions, and also dry skin, dry mouth, and urinary retention, and increased muscle tone. So that can also be, and tremors can also be present in the case of antimuscarinic action. It also acts as an antagonism to the postsynaptic alpha adrenergic receptors. So alpha receptor, alpha 1 more than alpha 2. So due to the alpha 1 receptor blockade action, patient can have sedation, miosis, and also patient can have a reflex tachycardia and orthostatic hypotension. And if patient is having an alpha 2 action, will be usually a mild hypotension. And inhibition of norepinephrine reuptake. Norepinephrine reuptake will usually lead to agitation, mydriasis, and also presence of diaphoresis, and tachycardia will be present. And early hypertension can also be seen in that. And if there is absence of serotonin reuptake, so inhibition of serotonin reuptake will lead to sedation, mydriasis, and also patient can go into a myoclonus or hyperreflexia. So that is the symptom of serotonin reuptake inhibition. And if there is then it's based on the voltage gated potassium and sodium channel. So it also acts it inhibits the potassium and sodium channel also. So by inhibiting the sodium channel, it leads to the impaired conduction. The conduction blockade is what is occurring, and which leads to, in ECG, can lead to a wide QRS. And also presence of other conduction abnormalities in the heart leading to a cardiac heart blocks can also occur. And wide complex tachycardia can occur. Patient can move into a Brugada complex, and also ventricular tachycardia can also occur, and patient can go into a hypotension also. If inhibition of voltage gated potassium channel is affected, patient can move into a QT prolongation. Again, ventricular ectopics and torsades pointus polymorphic ventricular tachycardia can occur.
Okay. So what all extra things? How many extra actions it is having?
So it's having action against mainly the histamine receptor and also in the sodium gated. And
How many number?
it's actually total based on the receptor is 7, 8.
Okay, so the thing is, as we told, presynapse and postsynapses are. So in the postsynaptic region, there are some receptors. In that region, it might get affected. It can block all these things. So what is happening is, if at all, it can affect central and peripheral receptors. It can act. So if it is affecting the first, what did you tell?
It's basically
Histamine
about histamine
receptors. So
receptor.
histamine, it can act central and peripheral histamine receptor. So as we told, antihistamine action will come if it is blocking that. So antihistamine effect is, patient will go into prolonged sedation, delirium, like that patient will go. Then next one is muscarinic action. So muscarinic action means it will block the muscarine receptor. So what will happen? Patient will go into a
State of
anticholinergic effect will. What are the? So there are central and peripheral anticholinergic effects. So what are the anticholinergic effect?
so
Just like we give atropine. We give atropine for OP poisoning. So what are complications will happen if we give extra atropine?
there will be some urinary retention, tachycardia, dilated pupils.
Dilated pupils will be there, tachycardia will be there, or retention will be there. There can be hypotension, these things can be there, fever, sweating, all this. Fever can be there, not sweating. Okay. So such things can happen because of the muscarinic effect. That are the second one. Then it will go and affect the GABA channel. So GABA is what type of neurotransmitter is GABA?
It's inhibitory
action. So inhibitory action will be blocked. So what can happen? Brain will get excited. So there is high risk of seizures. So these patients will have a risk of seizure. Then what will happen? Then alpha receptors. Alpha receptors either in the brain or in the heart also it will happen. So alpha 1, alpha 2 action will be there. So because of alpha action, there can be a bradycardia with the or tachycardia can happen, and there can be orthostatic hypotension. With alpha 1 blockage, orthostatic hypotension can occur. Okay, so reflex tachycardia and orthostatic hypotension can also happen in this scenario. Okay. Then what is the next action?
Then in serotonin receptor.
Serotonin receptor. So serotonin action is the thing which is required, but if at all it becomes extra, patient will go in for myoclonus. These things will happen. That because that happens as a side effect because of the serotonin receptor. Then is the sodium and potassium channel. So usually what is important for the heart? Which is the important electrolyte for the heart? Calcium is there, but there is no calcium action for tricyclic antidepressant. So other which is important, sodium or potassium is more important for heart? Potassium. So as if patient is having hypokalemia, heart will get affected. There can be ECG changes. Hyperkalemia also ECG changes will be there. But in one area, heart is requiring sodium. That is for the conduction area. So usually if the sodium channels are getting affected, in that patients we usually see this thing, Brugada syndrome and all. What is Brugada syndrome? Sudden cardiac death. Usually. What will their ECG look like?
Teen versions in
it is Brugada syndrome means history of sudden cardiac.
QT prolonged.
No. Usually these patients will be coming with a history of syncope, and if we are asking, they might have a history of sudden cardiac death. History might be there. What will their ECG look like?
V1, V2, DT, deep S-way with T version.
Yeah.
Saddleback.
They will be having an ST elevation actually. Mild ST elevation will be there along with an RBBB pattern. So if at all a patient is coming to ER with an RBBB pattern and a history of syncope, we need to always suspect for a Brugada syndrome. So these individuals come with an RBB pattern with an ST elevation in V1, V2, V3. So that is the only role of, that is the most, one of the important role for sodium channels in heart. Otherwise in the repolarization, depolarization phase it is coming. Otherwise potassium is the one of the important things. So if the sodium channel is getting affected because of this, our patient might have RBB pattern because of the sodium channel blockade. Understood? Because it is the main thing in charge of the conduction pathway of the heart. So bundle branch block is coming because of that. And in the potassium channel, if it is affecting, what will happen?
There will be presence of wide QRS.
Wide QRS. Why wide QRS? It is preventing the potassium, it is preventing the repolarization. Repolarization is getting prolonged. That is why this thing is getting widened. Okay, so you told that these are the manifestations. Now when you are going back to airway, breathing, circulation, disability, what all things will you look? Usually all cases we look all this. So in tricyclic antidepressant patient, airway, breathing, circulation, what all things specifically will you check?
So in the case of airway, again, there will be no presence of pooling of secretion.
Will not be there.
No, will not be there.
Drowsiness
Patient will be
will be-
drowsiness.
So patient can have a seizure because of the histamine effect. Patient will be drowsy. So because of that, airway will get affected.
Yes.
Then breathing.
In breathing, patient will be. They will
Mostly
be normal.
Okay. Circulation.
And in circulation, patient can have tachycardia or patient can have a hypotension. So hypotension or there is also a possibility of a mild initial
Why
hypotension.
tachycardia?
Because of the anticholinergic
Anticholinergic action is there, and reflex tachycardia because of the alpha
one action.
Then BP
In BP, patient can go into hypotension
because of the alpha
blocking action, and also pupil there will be presence of dilated.
You told dilated pupil because
there will be this anticholinergic action.
But can patient have meiosis? You have already told.
Yes,
Because
that's
of the
also
alpha
blocking action.
So
Actually.
both changes can happen in the pupil.
Yes.
Okay. And patient will be sometimes patient will be dry. This thing will be urine retention, constipation, everything will be there. So sometimes we'll have to insert Foley's and all depending on that. So this much actions will be there, and that should be clinically checked in the primary survey. Okay. So you told you took an ECG. Why ECG and what all things to do? Check.
Yes. So initially we take this ECG because patient basically have this tricyclic antidepressants mainly affect the sodium and potassium channel, as I mentioned before. So in ECG we should mainly look for the classical. There are some classical changes in cases of tricyclic antidepressant toxicity. It's mainly there could be the presence of a sinus tachycardia. That's one of the feature, or there could be presence of a right axis deviation in the terminal 40 milliseconds of the ECG, and also there could be a prolonged PR, prolonged QRS, or a QT interval could be prolonged, and the right axis deviation is usually demonstrated by a positive terminal R wave in AVR and also a negative S wave in lead 1. So that's how the demonstration of the right axis deviation occurs. And also less commonly patient can go into an RBBB pattern or a ST elevation with the RBB pattern. The Brugada pattern can also occur in these patients, and also AV block, high degree AV block can also occur, and patient can also occur the polymorphic ventricular tachycardia like torsades pointer scan also occur in ECG.
So ECG, when you are checking, one thing is tachycardia will be there. So usually we say that there is a tachycardia with the bundle branch block. So heart rate will be high, but there will be widening of the QRS, QT, PR, and everything will be prolonged. So everything will be wide, but patient will be having tachycardia. So that is actually kept as a spotter for the exams, and also what poisoning is suspected, tachycardia with prolongation. Okay. So we will see tachycardia, that is correct. Then we will be mainly, you told that QT prolongation. Why is the QT prolongation happening?
Because of the potassium.
Potassium repolarization, that potassium efflux is getting affected. So there will be prolongation of the QT prolongation, then QRS prolongation will be there, and PR prolongation. Everything will be prolonged. Okay. So what is the importance of the QRS value? QRS.
Yes, usually in case of if QRS interval, if it's more than 100 milliseconds, there is increased chance of seizure. There's increased risk of seizure potential, and also if QRS is more than 160 milliseconds, there's a possibility of ventricular dysrhythmias also, like ventricular tachycardia can also occur. So
okay, so then next of the thing is what you told about this thing, AVR. AVR, there will be a right axis deviation. Then comes the importance of R wave. So where will you check the R wave in case of TCA poisoning?
In poisoning, we'll be checking AVR. So there will be
AVR, we need to check the R wave. R wave should be?
R should be positive.
Positive means R by S ratio should be more than 0.7. We need to check the ratio. AVR we need to check. AVR we need to check the height of R wave and S wave, and R by S ratio should be more than 0.7. Or R wave should be more than 3 millimeter. Because AVR we are expecting everything to be negative. So AVR is, if R is getting positive, then we will have to suspect this scenario. Okay. Then because of the sodium channel blockage, as we told, like in Brugada pattern, there can be RBB pattern can be there. Other conduction blocks like bundle branch blocks and heart blocks can also happen.
So that's how the ECG can occur in such individuals. And in this patient...
Okay, so this patient we told it's tricyclic antidepressant. What is the peculiarity of tricyclic antidepressant? It is having therapeutic index?
It's having very narrow therapeutic index.
So this patient came with overdose. So a patient who is already on tricyclic antidepressant can come with a fatal dose or symptoms of overdose, because it is having a very narrow therapeutic index. Another peculiarity is that it is getting very fastly absorbed. Within 6 hours it will get absorbed, and it will, from the blood it will go directly into the tissues, to the brain, heart, everywhere it will go. So it is not at all dialysable also. So, and if the patient is not coming with an overdose, if this patient came late, right? So if the patient is coming within 1 or 2 hours only, we will be able to do a gastric lavage or something. So otherwise it will get absorbed to the body very fast.
So in the toxicity, basically the injection, if it's less than 1 milligram per kg, it's non-toxic dose. If it's a life-threatening, symptoms are usually occurring in dosage if it's more than 10 mg per kg, and if like fatal dose is more than 1 gram. And if patient is having more than 2.5, has taken more than 2.5 milligram per kg, patient will have some signs of toxicity will be present.
Any importance for the blood TCA level? So we usually take blood urine samples for checking the levels. Any importance for that?
No, only on TCA. In this case, we usually prefer taking urine tricyclic antidepressant level compared to the blood.
The thing is, one thing is, it is not important to know how much is the blood level of the tricyclic antidepressant, because it is getting absorbed very fast to the tissue, so we won't be able to know. One thing is there. But if at all we are getting a blood value more than 800 nanogram per ml, that is considered as severe fatal toxicity. Okay.
Yes. So in this individual, basically the sample history, the patient had a known case of clinical depression. So he was presented to ER with complaints of deliberate self-harm, allergic history of deliberate self-harm by consumption of 10 tablets of amitriptyline.
Okay, so how much total?
It was 250 mg. It was 250 milligrams. So it was just above the less than the toxic dose. And she was noticed to be drowsy by her mother just 2 hours back to the arrival to the ER. And there is no history of any confusion or any slurring of speech. There was no presence of dry mucous membrane or any urinary retention. No history of any chest pain, palpitation or any associated seizures. And there was a history of giddiness while standing. And no history of any blurring of vision or headache. And the allergic history, patient is allergic to penicillins, and medication history, she was on tab triptomer and also tab acetalopram 0.5 mg. And So initially on the examination, the patient was conscious, drowsy, but irascible. CNS power, power was 5 limbs, and the upper abdomen also was soft, non-tender, and the chest was clear, and CVS was S1, S2 was normal, and the rhythm was regular. There was no presence of any murmurs. And then initially, so since this patient has come like after now 10 hours of presentation, so initially we couldn't, there was no need of any GI decontamination for this patient, because GI decontamination is indicated usually if patient presents within 1 hour of intake. Within 1 hour of intake, if his patient is having a patent airway and patient is awake, his sensorium is completely full, we can go for a activated charcoal. So activated charcoal is one of the management which we can give initially. 1 gram per kg per hour can be given, and we should not give bowel irrigation or multi-dose charcoal or this gastric lavage also.
What is multi-dose activated charcoal?
It's like 50.
What is activated charcoal? How will we get activated charcoal? Through Riles tube we will be giving.
Yes.
1 gram per kg we will be giving. Why we are giving multi-dose activated charcoal? In this scenario, it is not important because it is get absorbed very fast.
Yes.
Otherwise, when all will you consider giving multi-dose activated charcoal?
Release tablets.
Sustained release
Sustained
tablets.
release tablets.
So how often will you give multi-dose activated charcoal? Every 4 hours.
Every 4
So sustained release tablet, especially coated aspirins and all, if the patient is taking, every 4th hourly we will have to give 1 gram per kg activated charcoal through the Riles tube. Maximum 50 gram for an individual.
And this treatment of TCA poisoning, if patient is presenting initially as presenting hypotension or presence of any dysrhythmias, for the dysrhythmias, if patient is having a QRS more than 100 milliseconds.
No, first you tell about ABCD. First airway we will have to stabilize if at all patient's airway is not airway is compromised. Then circulation, we will have to check the heart rate and also the blood pressure.
Yes.
So what will you do if the blood pressure is low?
In blood pressure is low, usually we must initially start with IV fluids. So if patient is still refractory to IV fluids,
How much IV fluid will you give?
it's actually 30 ml per kg can be the maximum.
Okay.
10 ml per kg to 30 ml per kg. 30 ml per kg is the maximum that we can give. Even if it's refractory to the giving the IV fluids, we can start on sodium bicarbonate.
Sodium bicarbonate for BP,
Yes.
blood pressure.
Yes.
That is the antidote.
Antidote.
Antidote you can give, but for the blood pressure as such,
We
what,
should give inotrose.
what the agent will you give?
Inotrose you should give a noradrenaline.
Norepinephrine, because our problem is our drug is inhibiting the norepinephrine, so we can give norepinephrine.
Norepinephrine, yes.
Anything that we won't give. Agents like dopamine and all, it will increase the heart rate. Okay. So suppose this patient is having tachycardia. So we told about hypotension, tachycardia. What all things will you give? What all things will you won't give? Any contraindications?
We should not give beta blockers or
Why beta blockers?
we already patient is having this beta blocking action.
Sorry?
Beta blocking action is already no.
No. Suppose patient is having tachycardia is there. Anything that we should avoid? What all are the antiarrhythmic agents?
We cannot give this class 1 antiarrhythmic.
Why?
Because that can lead to QTC prolongation.
Class 1 is what type of antiarrhythmic?
It's the sodium channel blocking.
Sodium channel blockage agent. So
yes.
if we are again giving sodium channel blockage agent, that will cause problems. So avoid giving class 1. Any other classes we need to avoid?
And even beta blockers and calcium channel blockers. Then
Why beta blocker again?
and the class 3 antiarrhythmic also.
So class 1 is sodium channel blocker. Class 2 is beta blocker. Class 3 is potassium channel blockers. Here what is the problem? Sodium channel and potassium channel is getting affected. So we are not supposed to give class 1 and class 3. Class 2 beta blocker is somewhat okay. And what is the class 4 of antiarrhythmic agent? Calcium channel blockers. So mainly we need to focus not to give class 1 and class 3.
Yes. And then the management is mainly about hypokalemia. Like if patient is having hypokalemia, we should give correction for the hypokalemia.
Why patient is developing hypokalemia?
In TCA toxicity, there is possibility of patient going into like if patient is having underlying hypokalemia, we should correct
It is not because of that. If we are giving soda bicarbonate, there will be a risk of hypokalemia
because of
that.
alkalosis.
Okay. So, what is the antidote of choice? Soda bicarbonate.
Yes.
When all will you consider giving soda bicarb?
Soda bicarb is usually given in cases of patient is having a hypotension. We are having we give IV fluids, and if it's still refractory, patient is having a dysrhythmias. Then we should.
So hypotension is not a preliminary indication for giving. The thing is hypotension, all hypotension patient, if you're planning to give soda bicarb, then that can cause respiratory depression, and we might have to intubate the patient. So we can give fluids, we can give other agents, norepinephrine and all. But if at all the patient is having any other effects, because tricyclic antidepressant mainly affect the brain and heart. In fatal cases, it will affect the brain and heart. If at all the patient is having symptoms related to the brain and heart only, we will have to consider giving. Any risk of arrhythmias, any widening of the QRS complex, if that is there only, we will have to plan giving. Okay.
Yes. And if
So how will you give soda bicarb?
Soda bicarb is usually given as 1 to 2 milliequivalents per kg IV bolus. Then then we can give one more repeat bolus can be given, or we can add 150 milliequivalents to 1 liter 5% dextrose at 2 to 3 ml per kg per hour. So that is the infusion dose. And we must always look to maintain the pH, blood pH between 7.5 to 7.55.
Okay. So in this scenario only there is high risk for hypokalemia. In that case, we will have to correct with the potassium. Any role for 3% saline?
Yes, in cases of 3% saline, usually if patient is having a torsades point.
What is the management of torsades point?
Initially we give it magnesium sulfate, 2 gram IV we given. But if patient is still not like refractory to that initial treatment, we can give 3% saline, 1 to 3 ml per kg IV. Over 10 minutes can be.
It is actually for the sodium channel blockage action. That's why to compensate for that only we are giving 3% saline.
3% saline. And then we can consider like pacing also if patient is having bradycardia.
Okay.
So
for seizure?
Seizure we should ideally give benzodiazepines, and which is usually a and phenobarbital can also be given, but we must avoid giving we should avoid phenytoin. And phenytoin is again having a sodium blocking property, sodium ion blocking property. So that's why we must avoid. And even flumazenil also we can give.
Flumazenil, the thing is, flumazenil is not required in case of tricyclic antidepressant poisoning. If the patient is having along with that benzodiazepine, along with the tricyclic antidepressant, we will have to prevent giving flumazenil. Why?
Flumazenil is taxing.
You should have told the word flumazenil, because flumazenil is not required for a tricyclic antidepressant poisoning. If it is a benzodiazepine overdose, only we will be planning to give flumazenil.
Yes.
What is the side effect of flumazenil? Seizure.
Yes.
So already, if at all a patient is having a benzodiazepine overdose, if the patient is having a co-injection with something else, then we shouldn't give flumazenil. So tricyclic antidepressant, if it is co-ingested with benzodiazepine, don't even consider flumazenil. Okay.
Yes.
Then based on the anticholinergic effect, if the patient is having any urine retention, we'll have to place Foley's, rest of things we'll have to monitor, and always keep a watch on the QRS. So if the QRS is more than 100 millisecond, there is risk of seizure. If it is more than 160 millisecond, there is always chance for arrhythmias.
Okay. So then ideally the symptoms will usually flare up in the within 6 hours to 12 hours of the ingestion of the tricyclic antidepressant. So we must always, in initial presentation, we must always keep in monitoring for at least 6 hours. If patient is asymptomatic till 6 hours, ECG is normal, and patient is completely fully conscious oriented, we can discharge the patient. But if patient
usually the absorption and the actions will come within 6 hours, from 6 hours onwards. So we'll have to monitor another 6 more hours.
Yes. And this patient, so initially we had monitored and otherwise like her sedation had like improved. She had GCS had improved.
The sensorium.
Sensory had improved, and then she was discharged.
She was discharged after psychiatric
Psychiatric
consultation.
consultation,
So we
yes.
don't want her to overdose again. So after psychiatric consultation.